Good afternoon, everyone, and thank you for taking some time out of, I'm sure, everyone's busy day to hear about all of the new and exciting EMS funding programs that were enacted by the Minnesota legislature and the administration during the 2025 legislative session. It is great to be with all of you today to share some of the specific information that was outlined in the various special session law that was just recently passed. So here at the Office of EMS, we have taken a deep dive into the pieces of funding legislation and trying to give you today the top line information that we have, how we expect these programs to work, how much funding is available for each program, and what some of those different requirements and eligibility criteria are. I will say that this was a very good legislative session for emergency medical services here in Minnesota. Um, I believe that the message is being received loud and clear by members of the legislature and the administration, that EMS, particularly rural EMS, struggling from a financial perspective, from a workforce perspective. And here at the office, we are very excited to have the opportunity to implement these programs. And certainly, we're going to focus on implementing those as quickly and to the best of our ability. So what we're looking at today, we have four different programs that we're going to focus on in the majority of today's webinar. The first is going to be some changes to the existing EMT education reimbursement program, what we commonly refer to as VER, or the Volunteer Education Reimbursement Program. The second program we'll talk about is the Rural EMS Uncompensated Care Pool program. Then we are going to discuss the new Ambulance Service Training and Staffing Grant Program, more commonly referred to as Earn While You Learn programs. And then we'll close out today's webinar with a discussion of the newly created Ambulance Operating Deficit Grant Program. So these are the four programs that we're going to cover today. As the introductory slide showed, just because we have so many people on the call, just shy of 100, we did set this up as a webinar, so everyone is in listen-only mode. However, at the top of your Teams screen, there should be a Q&A button. If you have any questions throughout today's presentation, drop your questions in that Q&A box, and I will try to monitor the question and answers as I go through the presentation. And with that being said, we'll get started with program number one for education reimbursement program specific to EMTs. The highlights of the policy changes during this legislative session were increased reimbursement amounts for EMT courses. Presently, a volunteer or an ambulance service can apply for reimbursement for a qualifying volunteer ambulance attendant up to $900 for an initial EMT course. The legislature increased the amount that can be reimbursed to the state to $1,200. This is more consistent and in line with the actual costs being faced by ambulance services and the costs associated to education programs with having to, provide that education. A couple of things, though, that we really want to emphasize. Pursuant to the law, and this has always been the case, but only Office of EMS approved EMS education programs are eligible for reimbursement. So whether it's an initial course, whether it's a refresher course, it has to be administered by an EMS education program that is recognized and certified by the office in accordance with 144E. Generally speaking, if you are using, exclusively distance education and that distance education is not part of a Minnesota program requirement, typically those are not eligible for reimbursement. There was also an increase to the refresher EMT reimbursement rate. I believe today it is at $375, and that amount has now increased to $400. So we've seen some increases to those reimbursement rates, and that's a net positive. Particularly for those services that really rely on those state reimbursements to help offset the costs of initial and refresher education. The new maximum reimbursement rates, so this new $1,200 rate and this new $400 rate, are going to be effective for any education reimbursement applications that the office receives on or after today, being July 1st. As that's going to be the enactment date for this particular section of the law. So if your service has previously submitted reimbursement applications and you're still waiting on payment, those payments will be processed under the previous amounts of the $900 and the $325. So there were also some other changes related to this program. Up until now, emergency medical responder education was not eligible for any reimbursement, either initial or refresher. And because of some of the staffing changes that the legislature made to ambulance staffing over the course of the last couple of years, to allow for an EMR to be able to provide more care and more staffing on an ambulance, it was felt that they should be eligible for some level of education reimbursement so long as that EMR is affiliated with a licensed ambulance service. So emergency medical responders who are still working independently or only working for medical response units or working for law enforcement, those emergency medical responders still remain ineligible for state reimbursement, but EMRs that are associated with an ambulance service are now eligible. Initial EMR courses will now be reimbursed up to $600, and refresher EMR courses will be reimbursed up to a $200 maximum. Now, this applies for both EMRs and EMTs, is that the Office of EMS is only permitted to reimburse up to the actual expenses that the ambulance service incurred. So if you got a really great deal on your refresher education and that refresher education was $200, you would only be able to apply for reimbursement up to the $200. It's not a flat rate that is given to everyone. We do have to have invoices, receipts, canceled checks to be able to ascertain what was the amount that was actually spent. And that was a finding of the previous Office of Legislative Auditor audit that was released back in 2022. Again, though, for EMRs, for the reimbursements, only courses that are taught by OEMS approved education programs qualify. And because we are doing EMR courses for the first time, as opposed to just increasing the rate, EMR initial courses or EMR refresher courses will only be eligible for reimbursement if they were completed on or after July 1st today. So courses that are completed today on for EMRs are going to be reimbursable, whereas for EMTs, based on when we get the application, the new rates will then apply. And we'll do another webinar on this next topic. But one of the changes that you can anticipate to the education reimbursement system is we're looking to transition that to being an all electronic process that ambulance services will be able to apply for within e-license. And we really think that will help. It will help with our efficiency, and it should also help significantly with ambulance services and the small city clerks. So we're not shuffling paper applications either through the mail or email, and have an opportunity for those to be lost or misplaced or somehow damaged along the way. So the way that we are anticipating it, a service will be able to go in, select multiple people, and then select the course that they're looking for, and hopefully be able to submit it as one application package rather than having to complete a separate paper application for each one. So more on that to come in the future, but all of these other provisions are in effect immediately. There are also some other changes related to the program, which are even a little bit larger, and it relates to expanding eligibility for ambulance services that can participate in this education reimbursement program. Previously, reimbursements were limited only to those staff that met the definition of being a volunteer ambulance attendant. As of today, that is no longer the case. Reimbursement is no longer limited to solely volunteer staff. And as a result, more ambulance services throughout Minnesota are going to be eligible for this particular program. There was one provision that was written into the law that says that ambulance services are eligible for reimbursement under this program only if they had fewer than 5,000 total responses. That's any type, that's 911, interfacility altogether. But if they had less than 5,000 responses in the previous calendar year, they will be eligible to apply for education reimbursement. Now, one of the things you're going to hear me talk a lot about today with some of these different programs, particularly for entities that hold multiple licenses, how the office will consider that in terms of counts and in terms of how that run volume is going to be calculated. So for this particular program, for services that have multiple licenses, each license, i.e. primary service area, will be treated as a separate entity. Meaning if you have, maybe your service owns 2 licenses and you're operating in 2 different areas, for the purposes of the education reimbursement program, we will treat, looking at that 5,000 total response count, we will consider each of those licenses individually. But we will only consider them individually if you report within MinStar at the individual license level. There are many services that is exactly what they do. If they have 2 or 3 licenses, they report out to OEMS through MinStar separately. There are a handful which still kind of report out at a higher level and don't go down to the individual license level. But the reason for that determination is we have to have the ability to, assign where those responses should live in terms of which license. So we think that there will be a significant number of services which will be eligible for this new program. Also, the legislature did provide an additional $400,000 appropriation into this program, with that $400,000 appropriation split between fiscal year 26 and fiscal year 27. So we're broadening the eligibility criteria and putting more of an appropriation in to be able to fund this program and increasing the reimbursement rates. So there are a lot of positives there. Also, we had written into the language to make it clear that if for some reason the appropriation essentially, if it was so successful that it ran out of money in a given fiscal year, we made sure to write in that services would still be able to resubmit their applications in the next state fiscal year, similar to kind of how we handle Cooper Sam's. So that is what we have related to the Volunteer Education Reimbursement Program, which will really now probably just focus on being the BLS Education Reimbursement Program. And also, like I said, if anybody has any questions on any of this as we go through, feel free to use that Q&A function, and I'll keep an eye on that as we transition through the different programs. The next program that we have is something of a bit of a novel program. I am really not aware of any other state in the country that it has kind of taken a look at a program like this at a state level, but is the Rural Uncompensated Care Pool. So in terms of ambulance service eligibility for this one, the ambulance service must be primarily located outside of the metropolitan counties. And you're going to hear me use that term a couple of times today. But the law defines metropolitan counties as Anoka County, Carver County, Dakota County, Hennepin County, Ramsey County, Scott County, and Washington County. So if a primary service area or a license has the majority of its square mileage within one of those counties, that ambulance service would not be eligible. Additionally, licenses that are specialized life support are also excluded. This program's language, though, when it comes to the multiple licenses and the multiple primary service areas, the law instructs OEMS to treat all licenses and all PSAs that are owned by a corporate structure as a single entity. So if you have a situation where you have multiple licenses, all of those licenses and all of those counts will all be treated as one. For this program, the legislature appropriated approximately $4 million that'll be available in state fiscal year 26, and an additional $4 million that will be available in state fiscal year 27. As it stands today, this is the only reimbursement program that we're talking about today that has continued funding in the tails. And what I mean by tails is when the legislature constructs a budget, they create a budget for the legislative biennia that we're preparing for, in this case 26 and 27. And then also they will create a projected budget at the same time, looking forward into state fiscal year 28 and state fiscal year 29. And as it stands right now on the budget spreadsheet, the legislature has, essentially tentatively appropriated. It can always go away, but $3.7 million in state fiscal year 28, and another $3.7 million in state fiscal year 29, and that essentially continuing on, and unless there were to be a change in law or a change in the budget spreadsheet. This year's, this biennia, so the 26 and 27 funding is coming from the state's general fund, whereas the 28 and 29 funding and beyond is actually being funded by the Minnesota Healthcare Access Fund. So in terms of funding streams, that's where that funding is going to be coming from. So the uncompensated care pool uses a points-based reimbursement system. So this will essentially work quite similar, although not exact, to the $24 million emergency aid program that was administered by the Office of EMS and the Department of Revenue at the end of 2024 and at the beginning of 2025. But for this program, funding is awarded for up to 200 qualifying responses per ambulance service. So in order for a response to count towards that total, there are a couple of criteria that have to be met. And very broadly, the EMS response could not have resulted in a transport to a hospital emergency department, and the EMS response could not have resulted in payment from any type of source. So there are some other requirements that we'll talk about on the next slide. But the way that this will work is reimbursements are going to be based on a sliding point scale. So let's say that let's say that your service has 50 qualifying responses. For your first 25 responses, you'll be awarded 10 points for each of those 25 responses. And then for the next 25 that your service may have, you'll be awarded 5 points for each of those responses. The maximum number of points that any ambulance service can obtain is 625 points. That is the max if a service has 200 responses that meets all of the different criteria. And we'll get into here in a slide or two exactly what those points mean and kind of how that math works out. So in order for a response to be counted as a qualifying response and to obtain points, the response must meet all of the following criteria. The first is that it has to have been a response for an ambulance. A licensed ambulance must have responded. No other vehicle types are going to qualify. So it's not a case where if a supervisor responds in an SUV and then cancels because the ambulance isn't needed or they're going to get a refusal. A licensed ambulance must be on the response. In terms of call origination, the call must have been it must have come into a public safety answering point, PSAP 911 center, but it has to be through a PSAP and considered an emergent, essentially an emergent response. Interfacility transfers in this instance generally don't qualify. We kind of already talked a little bit about this one. No emergency department transport. However, I do know that there are some services that are transporting patients to alternate destinations or destinations other than a hospital, other than an emergency department. Sorry. It is the case where, let's say that maybe you transport a 911 response to a more appropriate location. So maybe maybe it is a opioid overdose and the person is transported to a treatment facility, or maybe you have a 911 behavioral health patient that is taken to a more clinically appropriate environment in accordance with protocols set by your medical director to a destination other than the emergency department. If all of the other criteria are met, this would still count as a qualifying response and would be able to have points awarded to it. The next requirement is that the ambulance could not have been canceled en route. If you haven't reached the scene, and dispatch or someone says, "Yep, you can cancel, go back into service," and that's in line with your medical director's policies, procedures, and protocols, you can absolutely go back into service. but without reaching the scene, that should not be counted as a qualifying response under this particular program. And then the last key qualifier, and probably the most important of all of them, and why this program exists, is that no payment can have been received by the ambulance service from any source. Many of us are familiar with the fact that Medicare will not pay EMS for transports. Will not pay EMS for non-transports where we do not transport the patient under except some very specific criteria in cardiac arrests. So in some instances, perhaps the patient gets sent a bill for those. If the patient makes any type of payment on that, that would be considered payment received, and as a result, you would not be able to count that response towards your point total. We would highlight that it would be important to coordinate with your billing partners to confirm whether or not any type of payment was received, because there are some instances where Minnesota Care, state Medicaid, will make some payments, but under limited and very specific circumstances. I think most of the third-party insurers are still not paying for non-transport or alternate destination, and certainly Medicare is not. So those are the types of responses that can qualify and can kind of achieve those point values, which we're going to get into a little bit more on the next slide here. So in terms of the timing of how this particular program will work, the Office of EMS will generate a paper application. We anticipate it being a very simple paper application, or perhaps an online one as well, where it'll be very similar to your aid application that you submitted to EMSRB and to Department of Revenue. We will open that application process likely sometime in January of 2026. The applications will be due back to us no later than March 31st of 2026. And on that application, you're going to be asked to certify the number of 2025 responses that are eligible and that you feel meet all of the criteria that we just discussed on the last slide. What we'll do here at OEMS is we will compare your application to data that we see within the MinStar data reporting system, just to kind of do a check and to make sure that that data is consistent. And then we will calculate awards using a formula. So what we will do is we will take the state fiscal year appropriation. So in this case, $4 million for state fiscal 26. And then we're going to take that 4 million and we'll divide it by all of the total available points that were reported. And then that will assign a value of how much each point is worth. And then to calculate the agency payment, we'll take a look at the application that you sent us, and we'll do the math, and we'll multiply the number of agency points by the per point value, and then the state will either write a check or do an electronic funds transfer or a SWIFT payment, and the Office of EMS is required to issue those payments no later than May 30th of 2026. So with this program, the earliest that any payments will kind of come will be May 30th of 2026. Now I know there might be some of you wondering, well, how much funding is my service going to get from this? Well, hopefully, kind of from the math that you can see and from the formulas that we have, We will not be able to make a definitive declaration of how much each service is going to get until we receive all of the applications and we're able to assign those point totals per ambulance service. But we will, as soon as the application window closes, it should not take us long to be able to kind of calculate what people's anticipated award amounts are going to be. And then certainly we can share that information, and then the payments will come later in May. So that, in a nutshell, is the Rural Uncompensated Care Pool. And like I said, the intent of this program in general is to compensate EMS at least to some degree for, that cost of readiness where, we're responding to an incident. The patient doesn't need to go to the hospital, or perhaps there's no patient when we get there, right? And it's a case of, being able to help compensate EMS for that care that is otherwise not reimbursed by Medicare, by third-party insurers, and in some instances not reimbursed by Medicaid. The next program is the Earn While You Learn program, otherwise referred to as the Ambulance Service Training and Staffing Grant Program. So with this grant program, there are $2 million in state appropriations that are earmarked for fiscal year 26 and 27. And I think we actually have the ability to extend this one if we don't use all of the funds right away. I think we can go through state fiscal year 29 with these. What this grant program intends to do is to allow ambulance services to hire staff who have no clinical credential, Joe Q Public or Jane Q Public, and hire them up to full time and essentially push them through an EMT course. And the ambulance service can assign other duties to them if they bring them on as a full-time employee, doing clinical time in an ambulance, maybe some other ancillary or administrative functions. Conceivably, in some services, they could also operate as an ambulance vehicle operator. A lot of different ways that a service could kind of handle this. There have been several very successful Earn While You Learn programs that have been implemented in Minnesota. Some of them grant funded, others just funded by employers. But essentially, it's very similar to, if you're familiar with the trades, it's very similar to like an apprenticeship program. For this particular program, services will be able to apply for grants, and the allowed costs for these grants will be up to $26 an hour, which would include salary and benefits for the person that you're bringing on. Would be allowed to pay for EMT course tuition, could be used to pay NREMT exam fees, and it also can be used to pay for background checks. The legislation for this particular program, it was very clear. It was very cut and dried as to what expenses qualify in order to be reimbursed by the grant. And then a service can keep someone on this grant, subject to the available funds that you might be awarded, until a participant either becomes certified by the state of Minnesota, or they stop pursuing certification. So if they drop out of class, or they're ultimately not successful for whatever reason, then at that point they would have to cease being compensated by the grant agreement. So what we know right now about this particular program is that most ambulance services will be eligible for this program. Whereas a lot of the other programs had geographical limitations, this one did not. But the one requirement that there is that 50% of ambulance staffing in the previous year must have been staffed by an emergency medical technician. I think that probably most services in the state are going to meet this definition. There may be a handful that typically operate with a medic paradigm that would perhaps not meet this qualifying criteria, but the legislature felt that if we were going to be trying to bring in more EMTs, that they should go to those services that are actively using those EMTs the most. So unlike most of the grants and the programs that we do here at the Office of EMS, which are typically legislatively directed, these are not directed towards any one service. They're not directed to any one group of services. So the way that these will be handled will actually be via a competitive application process. Those interested will have to fill out an application and respond to an RFP that OEMS will share later on in state fiscal year 26. We will need a little time to perhaps have some discussions with the various advisory councils that advise the office in taking a look at maybe what some of those grading criteria or what some of those priorities should be in making those grant awards. But we will, when that request for proposals is ready, we will share that information far and wide and really work to make sure that all of that information is equally available to all ambulance services in the state. Now, before I move on to the ambulance operating deficit program, I'm going to go through a list of questions that have come into the Q&A, and going to try to take some of those now. So the first question that I have, earn while we learn. An EMR going for EMT would not be eligible as they are certified already and working at that level, ? That's a great question. And actually, I do think that if someone was an EMR and they were looking to upgrade to EMT, I do believe that they would be qualified to undergo this program. So if perhaps you had a volunteer EMR and you perhaps wanted to maybe bring them on as a paid EMT, you could certainly do that under the grant and be able to pay them their salary and benefits while they're in school up to that maximum allowable $26 an hour, and cover all their education costs associated with that. The other aspect that I wanted to kind of highlight is that and we will be looking very, very closely at anyone who's awarded one of these grants. No double dipping, so make sure that we also do not submit an education reimbursement request for any individuals that perhaps you would bring on under the Earn While You Learn program. So just something to be aware of. Related to the uncompensated care pool, we have a question of, are the calls and the responses based on a calendar year, or are they based on a state fiscal year? Once again, great question. The legislation does specifically say the preceding calendar year. And also, just in case that question was related to the education reimbursement program for the 5,000 response limit, it's the same answer. The response counts look at data on a calendar year, so January through December, as opposed to a fiscal year. Another question which looks related to the uncompensated care pool. We auto mutual aid with a department, and sometimes we assess a patient, but the other department transports. Is that eligible? Also, how about standbys? Related to that one, with scenario number 1, so maybe we have 2 ambulances who respond. One gets there, makes contact with the patient, does an assessment, and then another ambulance ultimately ends up transporting that patient. Under the letter of the law, that ambulance service that did not transport the patient, so long as you didn't receive any type of revenue either from the patient or from the ambulance service who ultimately transported the patient, that would count. That is that would count because your service responded, provided a service, and then ultimately we're not reimbursed for that. And that's the general intent of the program. Standbys is a great question. I'm actually going to write that one down, and I will have to take a closer look and review that language. My guess is it probably will relate to what was the standby for. If it's a case where perhaps there was a structure fire and the ambulance responded as a standby for a typical like automatic alarm type of situation, I would say that has a higher likelihood. But if there are like previously scheduled standbys, such as high school football games or something like that, those would definitely not qualify. But I'm using these questions today to try to help generate some frequently asked questions, so that when we put some more written program guidance out, it'll be more helpful to services throughout the state. The next question that we have is related to the uncompensated care pool. Is an amount applied to a patient's deductible, but we are unable to collect from the patient, considered no payment received? Wonderful question. And for that one, bear with me 1 second, because I just need to reference the law and reference the requirement. And in that case, when I take a look at it, the exact legislative language is: the eligible licensee did not receive any payment for the EMS response from any source. So to that question about the deductible, but the patient's deductible was credited, but they did not make a payment to you. I would say that yes, that would be a response that would be eligible to be counted in the uncompensated care pool, because you as the ambulance service did not receive that payment. And I think that word receive is very important, because if it doesn't translate to dollars and cents tied to that response for your ambulance, I would say in general that would qualify. So great question. The next question that I have here relates to the education reimbursement program. Is the 1 year of service prior to application still applicable for reimbursement? The answer to that question is yes, particularly for it really focused that 1 year. language is really tied to the initial education programs. So if someone is going for an initial EMT, or if they're going for an initial EMR, it's going to be tied to it's going to be tied to the 1-year requirement of active service with the ambulance service before being eligible for reimbursement by the state. I will tell you that that was something that I did try to have a discussion with the legislature, but with everything that was kind of going on with the session, it was good to be able to get what we've got. And I think that as we see some more of these education programs kind of develop, and see what kind of that future usage is going to be, that perhaps there may be some opportunities to make a policy change related to that. And it looks like I've had a couple of other questions come in. Will this cover transfers to air care? I believe all we get is a small flat fee regardless of what care we may have done. So in those instances, those responses would not qualify, because it really focuses on any payment. So the amount that was received with the use of the word any, even if it's a small flat nominal amount, if you received any compensation for that, that would not likely meet the criteria stated in the law. And then another one that I've got here is, if we're paged out with the fire department, whether it's a grass fire or structure fire, would that be eligible? I think there's a likelihood that it could be, but like I said to the other one, when it comes to those standbys, I do need to just I need to give that one some thought, have some discussions, and certainly we can issue an interpretation on that. These are all great questions, and you guys are going to going to help me put this together, and help settle some questions sooner rather than later. What proof needs to be provided of billing a patient and no payment received for uncompensated care? Great question. Right now with this particular program, at least initially, I do not believe our intent is going to be to be looking for transactions on a one-to-one basis or requiring source documentation for that. It could be something that we look at in future fiscal years, since this is an ongoing program. But I think at this point, because it does state in the law that you have to certify to us those number of responses. And because of that certification, if something seems really out of balance, or out of whack, so to speak, we can always do some follow-up and audit that on the backside. But on the front side, I'm not anticipating people having to pull mountains of billing data to be able to be able to apply for this particular program. There are some of the other programs that we're going to talk about which are going to have a lot more documentation associated with them. But the way that this language is written, it doesn't really seem that that is going to be a significant lift. This one, like I said, will operate more similar to the 2024 Emergency Ambulance Aid Program than a lot of the other ones that we're discussing today. Let's see. Is there any, this looks like it's related to education. Is there any chance any of this will turn into a program like the, I'm guessing the MBFTE, the FIRE, to help departments afford training? They reimburse approved classes done by certified instructors or expenses for it. I think that there is always a potential for the education reimbursement program to change. I will say it's unlikely for that money to ever be provided up front. I think it will probably always operate on a reimbursement basis. In terms of the timing of, at least for the initial courses, of having to wait for a year, that one, to be honest, I would love to either shorten that or somehow simplify that, because there is an administrative burden that kind of is associated with that. Um, but it is my job to enforce the laws the way that they are written, and to try to advocate for some positive policy changes. And I think that that one is going to be I think that one is going to be open for discussion in future years, but I would not anticipate any immediate changes, because I think there's probably a desire to see how all of these different programs, how they have impacted the statewide EMS delivery system. But great question. Certainly a lot of ways to do things. And here at the office, our focus is we want to follow the law, and we want to try to reduce the administrative burden on you as ambulance services as much as possible. But we'll talk a little bit more about one of my favorite topics of bureaucracy in a little bit. And then I think the last question that I've got for right now, and then we'll jump into the fourth and final program, is related to the Rural Uncompensated Fund. Are there any rules related to call volumes? And the answer to that question is no. The only limitation on the uncompensated care pool is that the primary service area has to be mainly outside the major metropolitan counties. But the maximum that any entity will be able to achieve is 200. And once again, this is a program that takes all licenses owned by an individual corporate entity and treats them as one. So essentially 200 would be the limit, 625 the maximum points, but there are no other response limits related to the uncompensated care pool. Okay, I will take one more question. Please explain MinStar. And we do have some individuals, I think some county commissioners and some other individuals on the call who may not be traditional ambulance service model. But MinStar is the statewide patient care reporting system. So under Minnesota Statute 144E123, ambulance services are required to submit a patient care report to the state for every EMS response that they undertake, all patient contacts, and emergent EMS responses. There's a variety of different data elements that are collected according to a national EMS data standard. And so here at the state, we can see a variety of operational and clinical data points. So we know how many EMS responses an ambulance service has reported to us. So it kind of serves as a way to be a check and balance on some of these self-certifications. So that's what MinStar is. It is a very powerful tool, and I will encourage all ambulance services to please pay special attention to the data that you're submitting us. Please make sure that it's submitted timely, because more and more of these funding opportunities are being tied directly to the data that you provide to the state. So it is very important for those reports to be timely, to be accurate, to ensure that you receive everything that you're due, and allows us in the office to help showcase the great work, both clinical and operational, that EMS across Minnesota does every day. Okay, So the last program that we have, and this program may also generate some questions, is the Ambulance Operating Deficit Grant Program. By dollar amount, this is the largest program of all of the ones that we have discussed. There will be $8.2 million that will be available in state fiscal year 26. And there will be an additional 8.2 million anticipated in state fiscal year 27. So all in all, 16.4 million. This program directs our office to award grants and funds that can be used to cover both operational expenses and capital expenses of the ambulance service. So they used very similar definitions of operational and capital to what they did with the 2024 Emergency Ambulance Aid Program. We did push out previous funding guidance as to not an all-inclusive list, but I think there was 6 or 7 pages that provided different kind of acceptable uses or what the office and the Department of Revenue would consider an operational expense and what would be considered a capital expense, and acceptable uses for those. Now, the key difference with this program, though, is that these grants are directly tied to cost reports that ambulance services are required to submit to our office under Minnesota Statute 62J.49. If you remember, back in probably the middle of 2022, no, actually, I'm sorry, it would have been the middle of 2023, we did our first cost collection report here in Minnesota in over a decade. And these cost reports were separate from what most ambulance services had to submit to the Centers for Medicaid and Medicare Services for the federal cost reporting. But these grants are going to be directly tied to those cost reports. And for those of you who are wondering, did I do that? You probably did, but that was the SurveyMonkey information on costs that you would have received back in 2023. So the way that this program is set up, there is an operating loss formula. So the way that the legislation directs me to calculate is I have to take your cost report information, and I have to take the insurance revenue you reported plus the other revenue that you reported, and then subtract all of your operational and capital expenses for the reporting period. And then that figure will result in either an operating deficit or an operating gain. In order to be eligible for this program, ambulance services can only apply for funding up to their documented operating loss. So in using that formula, you have to have an operating deficit in order to be able to apply for a grant under this program. In terms of services that are ineligible, services that operate exclusively specialized life support, ambulance services that are mostly within the major metropolitan area of those counties that I listed off earlier, or if the ambulance service is mainly located within the regional hubs of Duluth, Mankato, St. Cloud, or Rochester. There was one very important piece that was included in this that I think will have a major impact for some ambulance services. The legislature has directed the office not to consider any funds that were received by the 2024 aid program. We are directed not to count that funding as revenue. So, I know that there was a lot of funding that went out the door at the very end of 2024. But for the purposes of that mathematical formula at the top, that is not going to be considered other revenue. So that revenue will not impact whether or not you had an operating deficit or an operating gain. Because the legislature felt it was probably fairly likely that the total amount of losses would exceed the appropriation, they directed me to, if that were to happen, that grants would be distributed proportionately. So let's say that the losses of the qualifying ambulance services were somewhere in the neighborhood of $25 million. And then let's say that your service made up 5% of those losses. What we would then do is we would take that state appropriation. So in this instance, the 8.2 million, and then you would get 5% of that, or of whatever that state appropriation was. So that's how we anticipate treating those proportional awards in the event that the attributed losses exceed the available appropriation. And then the last thing, and then I'm going to go through the questions that I've had come in so far on this program. This is a program where each and every license / primary service area will be evaluated individually. It won't be evaluated at the corporate level or for those that have multiple licenses, but it'll be evaluated at the individual license level. However, it will only be evaluated at the individual license level if the ambulance services submit cost reports at that level of specificity. So if you want all of your licenses to be evaluated on their own merits in terms of participation in this grant program, you will need to submit a separate cost report for each individual license PSA that you have. Otherwise, we can't accurately calculate what the operating loss was. If you would rather, still continue to report all of your license and PSA financial data together, perhaps you don't have cost centers broken out to be able to do that. That is fine, but we would then have to evaluate your operating deficit or operating gain at the structure level rather than at the license level. So I'm going to pause and I'm going to see what kind of questions that have come in. Let's see here. Okay. Question number 1. For operating deficit grants, a county has been proactive in establishing a levy to support ambulance services. Is this levy support included as other revenue? Good question. There may be some potential changes to this, but my off-the-cuff answer and response would be if there was local government funding, and also it can depend on it could also depend on what type of structure the service was. Was it a governmental? Was it a non-governmental? But in general, if it's a governmental service getting funding from a levy, if that levy was specific for emergency medical services and not just out of a general fund contribution, that would likely constitute revenue, although this is potentially subject to change. If you are a non-governmental entity and you're receiving levy funds from a political subdivision, that would definitely constitute other revenue. So this would be a situation where it could be there are a lot of intricacies to it, and when we go to put out the cost collection refresh of data that we're going to do, that is going to, this will be a good question that I'm going to write down. And we'll have to issue some more specific guidance on that so that ambulance services know exactly how to report, so that we can keep that consistent amongst all of the different reporting parties. The next question was, is the operating loss program for 2024 losses or 2025 or both? Great question. So actually for this, I'm actually going to move on to the next slide. So the way that we see this going down is that we will be sending out a new cost collection survey sometime probably late July, early August. And ambulance services will then need to report their cost information for the last completed fiscal year. So we know that there are some ambulance services, particularly ones that are operated by local government, that their fiscal year is January to December. There are others that operate in either nonprofit structures or maybe private for-profit structures where maybe they operate on a July 1 to a June 30. So the cost report will look at the last fully complete fiscal year on the day that you submit your cost report. And that is what we will be looking at. So it'll be looking at one fiscal year per ambulance service, and it'll be looking at the immediate preceding fiscal year as defined by that service. So I hope that answers that question. How will fire ambulance dual role staffed services operating losses be determined? Will there need to be a clear budgetary separation of fire and ambulance expenses? The answer to that is yes. There does need to be some type of separation because this is specifically and only permitted for emergency medical services expenses and not expenses for other public safety disciplines. So, and in terms of what category you're dealing with, there are a variety of different accounting measures and different cost allocation plans that would stand scrutiny to an audit. For example, if an entity regularly staffs 2 ambulances 24/7, 365, then it would be reasonable to have the FTE costs to staff those ambulances to be able to do that. If they are cross-staffed, it would probably behoove a dual service service entity to take a look at, okay, well, what percentage is looking at schedules, what percentage of time is the person detailed to an ambulance, what percentage of the time is someone detailed to a piece of fire apparatus, and then do a cost allocation that's attributable to that. But in terms of other types of apparatus costs other than ambulances, I would not, in general, I would not count those as either operational or capital expenses under this cost reporting. The next question was, does volunteer labor impact the calculation for deficit either as a cost and or a donated revenue source? Great question, because this is a fact and figure that we calculated previously, and we intend to do so again with this program. However, we do not anticipate the volunteer subsidy counting as revenue received by the service. Nor would we attribute that to a cost. It would largely be it's information that we want to know because we want to know how the services are being provided, and to be able to help show legislators and all of those making policy decisions the valuable contributions that our volunteers make to the system, so that we can continue to work on programs to support them, support their services, and also to be realistic about what EMS costs to operate. But the way that this is written in terms of actual money going out the door versus actual money coming in the door, it likely would not go into the formula. Are funds received through a taxing district considered in the ambulance's total revenue? In general, I would say yes, but similar to the levy question, there could be some unique intricacies that need to be considered on a case-by-case basis. And if that is the case, the Office of EMS will provide additional instructions in the cost reporting instrument. And certainly I stand ready to provide any and all technical assistance that I can to try to help services work through these types of more complex questions that may not apply to the overwhelming majority of ambulance services. Okay, as a county, if there is grant relief available to the non-government ambulance service, if we do not levy the taxpayers within the ambulance service district and discontinue providing relief, then we should decrease or discontinue our levy. Otherwise, our taxpayers are going to be paying twice. Once through property taxes, and again through the tax dollars being used to fund the operating deficit grants program. I think that's I think that's an interesting take, and one that's not completely without merit. However, there are a couple of very important cautionary tales that I would flag. The first is that this program, it's always going to be looking behind, right? It's always going to be looking at data that at a minimum is 1 year old. The other thing to be cautious about is that this particular program was not authorized beyond state fiscal year 27. It is a case where there is a very real possibility that this program, may not be reauthorized. It may not be in any version of it reauthorized. And a lot of that is going to depend on what the fiscal year 28-29 budgeting process looks like. Certainly, I'm sure many people on this call are aware of Minnesota Management and Budget's budgetary projections for fiscal year 28 and 29. So I don't necessarily know how well EMS is going to fare in future budget sessions. I also think that there is a high degree of uncertainty related to healthcare policy, particularly related to publicly funded insurance programs, Medicaid and Medicare, with different policy discussions that are underway in Washington. And certainly some of those policy implications do have the potential to have an adverse effect to ambulance services financial bottom lines, not only across Minnesota, but across the country. So none of these things are guaranteed, but I do think that we are in a high time of uncertainty. So ultimately these decisions are best made at the local level. But those are the things that I would encourage policymakers to consider. Remember, it's always looking backwards, and we don't necessarily know exactly what the future is going to look like, both in terms of healthcare policy or whether or not this program survives in any type of iteration beyond June 30th of 2027. If we are paid for standbys for events as a donation, will that be considered income to report for this program? Yes, fundraising, donations, those all constitute revenue under the law. Really, the only ones that I can think of, the emergency ambulance aid from 2024 is specifically excluded and is not revenue, and then the levy and the tax district. That one I'm going to have to take a closer look at, but almost anything else is likely to be constituted revenue if there are actual dollars and cents coming in the door. When will applications for this grant program be available? This one, we will not put out a grant application for this one until we have completed cost collection. We'll start cost collection again in July, early August. I would anticipate at least having a 3-month window to submit cost report information, because I don't want to place an undue burden on small to mid-sized ambulance services that may need some time to collect this information. That's a similar process to what we took before, and we anticipate going down that path again. So I do not anticipate seeing grant applications or additional guidance for this program until late 2025, early 2026. But once those documents are ready, we will definitely be spreading that far and wide. Just a couple of other things that I want to summarize with this program, and then I'll go back to the questions that have floated in. Just as a reminder, under the new law, cost reports that are submitted to the state are now subject to audit by the state. So it is important to be accurate with those, and it is important to be able to attest to the veracity of what you're sending to us, because there is the potential that that you could be selected for an audit, and we would need additional source documentation and to have a sit down to make sure that what was submitted is financially reliable, and that we can count on that information. The other aspect of these, unlike the uncompensated care pool funds, which are considered just payments for previous services rendered, under this program, these will be state grants. I will just highlight that right now, I'm sure a lot of you are aware, grants in Minnesota state government are under a high level of interest and scrutiny right now. And state agencies have a variety of different laws and policies that we have to follow related to administrative and financial oversight. So just some things to be aware of, because this is something that neither OEMS nor EMSRB has really had to do with individual ambulance services in the past. But anybody who gets one of these grants, depending on the dollar amount, would be subject to financial reviews, reconciliations, making sure that funds were spent on what you said the funds would be spent on, doing risk assessments, various reporting required by the ambulance services that receive these grants. And if the dollar amount is high enough, monitoring site visits from the state, really no different than when we show up for inspections. But rather than an ambulance inspection, we'd be coming to see, hey, how did, if you decided to apply for a grant and you wanted to use it to hire staff, hey, how are the new staff members doing? If you used it for equipment, hey, show us how the new Lucas is working out. But just so that we can lay eyes on what was told to the state of what those funds were going to be used for. And that's probably the biggest difference from the emergency ambulance aid program. So if you remember, with that program, the money went out the door. And if you received a grant, if you received not grant, but if you received an aid payment for that, you'll remember you have until December 31st of 2025 to spend that money. One of the things that we have to do is we have to find out from you via a report what you spent that funding on, and then I have to report back to the legislature. This one with the operating deficit program, that order is going to be a little bit different. The services will have to tell the state what you intend to use the funding for. We'll have a defined budget. We'll have a defined work plan, and then the state will be able to make payments towards your activities of that work plan. All of that, long way of saying we do not anticipate any of this funding being available before January of 2026. Because there are also, because of those administrative requirements, there will likely be some staffing that we'll need to plus up here in the office to be able to better serve our grantees that would be awarded a grant under this particular program. So those are the slides that I had for today, and I see I still have some more questions to get through. So I'm going to go ahead and get through those. Would providing a copy of the city's annual audit be useful in documenting the operating deficit? Fantastic question. I do think that it would be helpful. The more documentation that we can have to substantiate the cost reports, I think the better off that will be, both for my office and from the state, from being able to protect the program, and also to be able to protect individual ambulance services. Likely, if we can figure out how to do it technologically, what I would like to do is everyone will report their cost information just as we did a couple of years ago, but then would have an optional field, and it would be optional for services to be able to upload either an audit or if they have financial statements that are specific to the service, or any type of supporting documentation that they use to create that. For this cost collection cycle, it's not going to be a requirement, but I would like to try to collect it. The other aspect that I will remind all services is that anything submitted under cost reporting under the provision of 62J.49 is considered non-public data, meaning that while we as the office, we share an aggregate, we share the regional reports that we did, which was extremely helpful in helping push some of these funding initiatives through. But what you submit to us under those cost reports is not public information from our office under the Minnesota Government Data Practices Act. The one aspect, though, that would become public is if you apply for a grant, then that grant amount and perhaps your operating deficit, because that is needed to calculate said grant amount, would likely constitute public data, because now that's part of the grant as opposed to part of the cost collection process. The last question that I have in queue is, who pays for the state auditors? Good question. The way that this legislation does not impose any type of cost onto the ambulance service. It does not impose any cost on local government. So if there was a need for a what I would refer to as a full-blown audit, that cost would likely have to be borne by the state of Minnesota. But there are a variety of different levels to audits. There's the full-blown traditional, you send in a CPA and they look at everything from top to bottom, writing, required compliance reports and evaluating internal controls and the whole shebang. But there are varying levels of, it could be a desk audit, which would just be handled by some of our agency financial staff of, hey, we see this expense, could you provide receipts, or could you provide source documentation that substantiates, these expenses, right? So there's always varying levels of financial oversight that are chosen based on the perceived risk. But no, I would not anticipate any audit costs being borne potentially by only potential grantees, because that's not specifically enumerated within the statute. And unless a state agency has direct statutory or regulatory authority, in general, they cannot just promulgate fees on their own unless otherwise authorized by state law. So that is the presentation. I do not see any other questions in the queue. If you had previously put a question and you're like, Dylan, you did not answer that, please feel free to drop it in now. And I will happily stay on for another couple of minutes to make sure that no other questions come in. But I want to thank you all personally for joining us today, asking very thoughtful, insightful questions. I think that's going to help us frame some of this additional programmatic guidance. And just wanted to, get this information out as quickly as we could, because I know there are a lot of questions out there. But to all of our providers, all of our service directors, all our EMTs and paramedics, thank you for everything that you do. For all of our county commissioners, local government officials on the phone, thank you for everything that you do to support EMS at the local level. And I wish everybody a safe and happy 4th of July. Thank you. All right. With no other questions coming in, I'm going to go ahead and end this webinar. Thank you, everybody, for your participation today.